So the next one, actually, Steve Shannon's comment is a very nice introduction to this, which is, I think we all know that the last decade has seen an explosion of both quantity and complexity of simulations moving forward. And the question is, what's the right role of simulations versus, inverted commas, real patients? And really, from an educational point of view, where should we put our emphasis moving forward? So the proposition that I'd like you to vote on is a priority in the development of health professions education should be the development of robust simulations that can train and assess the variety and complexity of behaviors necessary to implement the triple aim. All of you who are in favor of that, hold up your banner.
Real patients or real community? Patients.
And real patient, I think it's a good point to make. This is a vote for priority in the development of educational programs. This was hotly debated, the language of this one. So all who are voting against the proposition, raise that. Hold them up until we get your votes. All right. So, Pamela Jeffries.
Hi, Pam Jeffries, President for Society in Simulation and Healthcare.
That's pretty good.
That's true, true. Okay, I've got 4 minutes to convince you. So climbing a steep learning curve no longer can be done by trial and error, as we have in clinical education today. We need new models, such as simulation-based clinical education. I know you had homework reading what simulations are, but very quickly, simulation is an activity or event replicating real clinical practice. And what's so grand about simulation, we follow it with debriefing or guided reflection. And we have evidence where learners are learning what they did wrong, right, and they connect the dots. It's overwhelmingly a positive. Anyway, what I like about SIMS before I get into some of the research is in student nursing, usually for traditional education, there's one faculty with 8 students, 10 students. We chase around on clinical, and when I'm there an 8-hour day, 10-hour day, all you get done is 8 o'clock meds, 10 o'clock dressing, 11 o'clock tracheal section. It's really task at the end of the day, a post-conference, what'd you do? I did, done. That's clinical education. I have no idea what my students did. I have no idea. They didn't get to talk about the complexity of the healthcare environment, nothing. It's very task-oriented. We do this for 4 years if it's a baccalaureate program, whatever. What I like about simulations is you get to immerse the students in this real activity or event that doesn't harm patients. You have standardized patients or mannequin-based that you're immersing them in. And the chief thing is we're immersing them in their scope of practice. So students play the role of the RN, students play the role of the physician, the intern, whatever that is. And that's the first time they get to play that role. Think about in traditional nursing education, they graduate, May 26th, they pass the NCLEX, and then the next day they're an RN. They have never practiced the scope of nursing, and until most recently, they didn't even talk to physicians because we have rules and regs in all these clinical settings, what we can and can't do. And there's more things that we can't do that's being pulled in education, just to let you know. From the medical side, I say, how many want to be admitted to the hospital July 1st? No, that's when residents change, interns change, they have new roles. A little scary, isn't it? Okay. There are forces driving simulations, many. One are lack of clinical sites. According to the AACN data, through the American Association College of Nurses, we turned away over 13,000 eligible students for graduate nursing education. We don't have the sites, we don't have the preceptors, we can't even enroll them, and they're qualified. Also, clinical competences is another force. We want to produce clinical competence before these students ever go and take care of patients. I think of the advanced practice nursing role. It's preceptor based. Many times we can't get enough preceptors. They're with nurses with one grand round, and if they haven't been prepared, then they don't get to go any further. So clinical competence, put them in simulations and all that. Also, we have increased research and evidence through this translational science in our professionals education. There's a study done by, it was Singer and Corbridge, saying the first-year medical students in a critical care rotation outperformed third-year medicine students because they had a simulation-based medical education curriculum. Also increased research, just to put it on your note, there's huge funding from National Council State Board of Nursing, multi-site study across 10 schools, looking at the amount of simulations we can actually substitute for real clinical time, and results will come out in August. Also, reducing cost per capita, going to some of those triple aims. There's research showing that use of simulation-based medical education costs are being saved. One was a nurse residency program where over $1 million was saved in 1 year based on simulations being incorporated in a program. Also cost savings on central venous catheter insertion, hundreds and hundreds of thousands of dollars when they have simulation-based education before. Also, other improvement for patient experience, their sites, OB training that's reducing the reduction in birth complications due to shoulder dystocia and the central line venous replacement. Lastly, simulations are being adopted by faculty. It does take faculty development and training, and no longer are simulation centers rare, but they are a global phenomena. They are everywhere. Thank you.
Hi, I'm Eric Holmboe from the ACG again, and it's pretty clear, given how long it took Pam to make her argument, that clearly she's struggling, believing herself. I'd also point out that there's a conflict of interest there. I think we probably don't need to go any farther. But I'm going to make a few observations nonetheless. I think the first is, if you think back to this morning's session, the word simulation did not come up once. It was all about relationships and building deep relationships, something simulation cannot do. And so we cannot lose sight, in fact, and she talked about substituting clinical experience with simulation. You cannot develop those relationships through that. The second thing is that it feels a little bit like a Spike Jonze her and a Kubrick Hal moment when we think we can begin to replace this stuff. We don't want to go there because of those relationships. And if we have trouble with regulations developing sites and preceptors, and that tells us a problem with the system, and that necessarily shouldn't be replaced with simulation. But also point out that there are some systematic reviews that have said that the evidence around simulation is actually quite mixed, in that we have spent a lot of time developing shiny, bright objects that are really cool and have high fidelity, and yet may have no more impact on things that are very low tech and much less expensive. We also know from several research studies, I reflect back on Perkins' book, he talks about playing the whole game. It's very tough to play the whole game. You can play parts of it with simulation, but playing the whole game means you've got to be in, kind of in the environment. And so, we think about the other parts of triple aim. Population health, kind of tough to bring a whole population into a sim center. Better to do that somewhere else. We also think about some of the other cost issues. You got to live that, right? That's not something that simulation can do, and it really gets back to the really final important point of how important context is. You have to be embedded in the context. And George Miller, of his famous assessment pyramid, says the ultimate goal is does, and that we really need to be spending more time doing under the observation tutelage of a really effective faculty member with robust ongoing feedback. And so for that reason, I'm going to end early and say, real is much better.
Good. Open it up to the group. Comments and questions. Yes, sir.
I would very much disagree that you can't bring the community into simulation. In fact, we've seen quite the opposite. You can take a look at all kinds of efforts that will bring the conditions of community into simulation. Take a look at the island that's being done by Queensland University and other places like that. So I think that's actually not true.
Good. Brenda.
Brenda Zieler, University of Washington. I think it's important to take note that simulation is used to teach, but it's also used as an evaluation tool, so it's not the same. Currently, we are teaching residents of central venous catheter insertions, but at the same time teaching nurses about observation of the patients, monitoring, teaching them in teams. Same with our moderate sedation, our point of care ultrasound. All things that we don't want them to do on the patients first. So it's a safety issue. And then we have a 4-hour curriculum that really focuses on the teams playing their own roles together, not having nursing students play the role of a physician, but each playing their own role around 3 clinical cases. And I think that I'm very much in favor of simulation.
Good. Open it up to the group. Maria.
So I would agree with Brenda that there's an important role for simulation, but I worry about how, I think there's an opportunity to be more thoughtful about the role that simulation plays. We put huge investments into it, and certainly in my own context, many of the sim centers are not fully utilized, and we haven't spent the time on the technical training of people to support the simulations. I think there's a lot we can learn from simulation, particularly around briefing and debriefing and how we bring that into real environments and not just into simulated environments. And what's interesting for me is what we hear from our students around the interprofessional curriculum. In a time when we think that students are driven by technology and high tech and the love of simulation, what they value most is real experiences in practice settings. So I'd love to see us think more strategically about how simulation is used and spend more of our time thinking about how we can truly transform the curriculum and make the hidden curriculum much more explicit through the best practices of simulation.
Good. Yes. Jan, and then in the back.
I want to share that if I give a clinical demonstration and the patient can't show up, the students are completely disappointed even when I use a video or another simulated kind of interaction. So the real stuff is. The other thing is, of course, from a Western perspective, you can afford the simulation technology, which is quite expensive. When you are working in Africa, simulation is, I don't think that it is an option, because those universities cannot afford to do that. So I think that on a world scale, we should be completely aware of that problem also.
Good. Corner back up there.
I'm a pharmacist by training and have had many students come through various types of rotations and have had the opportunity to work with those who are fresh out of school and have actually never really practiced at all. And part of that is because they aren't allowed to have the accountability of taking care of the patient. And the simulation will provide that level of accountability that they don't get until the first day that they step in with a pharmacy license.
Good. Yes, Patricia. Yep.
I guess I would like just a little clarification about whether we're talking about virtual and real or simulation and real, because there is so much beyond simulation that can be done virtually from the community to a variety of different ways. Also, in many of the sim situations where we have standardized patients, it's real as well. So it's almost, but the virtual needs to be a little bit more clarified because it's has just huge potential way beyond a machine.
Good.
I took it as anything not real. You know, not just
I knew
virtual.
you did.
Yeah.
So just again thinking a bit like Jan was from a more global perspective, and if you include low fidelity, then it's interesting that we've focused our conversation around improving the quality of our graduates, but what about the quantity of graduates? So if you look at the University of Nairobi, if you look in Ethiopia where class sizes have doubled, tripled, or quadrupled, now they have 20 students around one patient bed, and if they only train at the one center, students are graduating without having the opportunity to hands-on. So they're starting to use an established skills lab to provide that kind of hands-on training opportunities in order to scale up the number of health workers they produce.
Somebody? Yes, sir, in the back.
Yeah, thanks. It's Doug Hagemeister from the University of the Free State in South Africa and Africa. We do have several challenges there in terms of as a family physician, we do spinal anesthesia, we had vacuum extraction last week. There's a lot of skills that I wish I myself and our students would be able to learn in a simulation environment first. But then on the other hand, this morning we heard about the depersonalization that happens with our medical students, with ourselves. And my experience is that not only we depersonalize the patient, we basically subtract ourselves as human beings out of the picture. And for me, it's a very scary environment to have to do a skill that I haven't done before on a human being. It's not so scary to do that on a plastic body. So the very ontological experience of dealing with another human being is something that the simulation will not exactly be able to reproduce. And that comes in many different forms and shapes in terms of human conversation, the whole difficult area of signs and symptoms. And I think we need to balance that. It's, again, not an either or, but in both at the right time.
Good. Sir, right there.
Presenting virtual educational experiences is an easy thing to do if you're willing to do it badly, and a very difficult thing to do if you're willing to do it well. We have the advantage of training at community health centers around the country, and the disadvantage that that's going to lead to some unevenness in what our students experience and which competences we can clearly measure as we train all over the country at health centers. The use of simulation technology to be able to bridge some of those gaps is important if we can do it in a way that does not dehumanize. And so what we do now in our first year is that every single case that we're going to be presenting to our students in the first year of their education will be tied together in a family and with a patient background and with a health record. And our hope is that our students at the other end of their experience will not remember whether this particular factoid that they learned was learned on a simulated patient or a real patient, because the experience is the same.
Good. Thank you very much. Let's go, good comments. Let us go to the vote again. So a priority in the development of health professions education should be the development of robust simulations that can train and assess the variety and complexity of behaviors necessary to implement the triple aim. All in favor? Okay. All opposed to that? Good, thank you very much. And thank you to Pamela and Eric. But first, I want to say, what do you really think?
We both talked, we believe in both, you know, and the big question is, when do you use simulations and when do you use real clients and move into the clinical setting? I fully meant it when I think you need to front load many of our experiences and before the students go in and take care of real patients, particularly with any type of skill. We've been doing that for years, but even just, I think of pediatrics, when you send students in to take care of patients and families, the little children. If students don't know how to deal with families want the students to leave because it's such an awkward situation. I think you need both and probably determine a competency, then let them move on. I love that the deliberative-based curriculum that's going along with that's Erickson's theory with a lot of the simulation-based. It's a mastery level.
So believe it or not, I'm actually happy that I went down. I can see the numbers, and it's going to take me a while to recover, but I think I'll get there. Yeah, no, I think it's a both. I just highlight a couple of points, though, that were brought I think are really important. I mean, I do worry at times, and I've seen this where simulation becomes a substitution because it's too hard to do it right when it really should be in the clinical environment. I think some people highlighted that. It really shouldn't be a substitute for things that should be done in that environment because of the context and stuff like that. I totally agree with Pam, and again, the evidence actually is growing that you really, for many things, should start in the sim lab and work up through deliberate practice. The central line study at Northwestern is a really nice example that led to significant improvements for patients, decreased infections, complications, et cetera. I think the other thing was nicely said over here is that, you know, anytime you spend more and more time, you run into the problem of what we talked about this morning. That's the objectification of kind of patients and people, right? They become the object instead of the subject. And that's kind of what happens in simulation. You can certainly simulate that, but it's not the same as a longitudinal relationship. So I don't think we want to lose sight of that. But yeah, I honestly really struggled. I rewrote it out, even just that I, because I mean, it's really hard to argue that in this day and age, there are a fair number of things now that really should start in the simulator that really make a difference for patients. And that's hard to argue with. I mean, if that's the case, if that's our ultimate outcome, and that's what competency-based medical education is all about, that's where you start, then it's hard to argue that you don't need it, but it's the right purpose for the appropriate kind of goal. I think we have to pay a lot of attention to. And also, one last thing I'd say is we spend a lot of money in this high-fidelity fancy stuff. There's a lot of things you can do that's very low-tech and actually very effective. Like, for example, learning to use a snare on an end of a colonoscopy. You do not need a fancy simulator. Rubber rings will do just fine on pegs. So things like that we got to pay attention to.
Just to dovetail on that, simulations is not about the mannequin or anything like that. It's about the pedagogy and also the science, the research with simulations. It's embryonic. It's just, if you look at those level 1, 2, 3, 4, it's just getting into the patient outcome, but we're getting that. And simulations have exploded, I'd say, in the past 5 years. So this has not been around. I mean, you talk about the first simulator, Annie, or the Rossetti Annie, clear back in the 60s, but we weren't doing a lot of with simulations at that point. And lastly, the key, and I see this all the time, it's faculty development, faculty training on how to do simulations. You can have very, very bad simulations, what I would never buy into, but it's the quality of the training of the faculty that know the pedagogy and can deliver it. So thank you.
Good. Thank you both, Eric and Pam. So we have a few minutes with which we can talk about any of the issues that we've addressed or, in fact, comment about the use of debate as a kind of active learning technique. So I'd open it up to the floor as we go forward. Patricia.
I'd like to go back to something that was presented in the first one with admissions versus training. And what struck me, Rick, forgive me, is the word right. And we use that word a lot. So when he was talking about the right people on the bus and the right kind of thing, right is always in the eye of the beholder. And to me, that's also part of the problem that we have is who's right, what's right. So I don't know what a better term is, but I think that is a big stumbling block for all of the health professions.
I think that's right.
Ifaf and then Maddie.
Just a couple of comments. First of all, this was fantastic. This was a really good approach for all of us to participate. Thank you for that. Community-based, and how do we get that in simulated experience and virtual experience? We are all struggling with that, and this is an area that just really needs to be developed. There are opportunities for us to provide virtual communities for assessment and for participation but we don't really have good models yet. So I think I would urge us to think about that and develop those models. Second thing is related to longitudinal experiences. When we went into communities with students, we would go with a group of students, they would assess and do something, and then we would leave the community. And there is no continuity there. So I think longitudinal is not only about our students, but it's longitudinal for the community too. So if we engage in a community, I think we need to continue and build on the previous group of students so the community feels that we are doing something for them rather than.
Yes, good. Susan, Maddie, and then over here.
Okay, just building on what Afaf said, there are a lot of ways to work virtually with teaching communities. One of the ways that we're starting to explore a bit in anthropology is games, so that you can create communities, and probably most of us have stories about things we've done wrong or things we've done right. You can literally, in a game situation, create decision points. And if somebody can make a decision and then they'll follow through with the consequences, they'll have to assess it, maybe backtrack, make a different decision. So you really can bring community in the virtual piece of it. At the same time, there's no substitute for the real thing, which is why the both and is really the final answer. And I just want to reiterate there that the whole issue of how the community perceives us is a huge one. We're seen as spies. We're seen as people who take things. We're seeing like knowledge from people when we do surveys. I actually did research on community perceptions of healthcare and researchers. And some of the things that came out were just really shocking in that we just don't think about that. So it is critical to have the real experience. And I think it's critical for our health professions education institutions as well as for our students to have the continuity with the community. Because when you as an institution lose the respect of the community and how you're sending students out there, you've lost something huge, not just in terms of your educational opportunities, but in terms of your opportunities to do research and to make a difference.
Good. Thank you. Maddie, and then go.
As I've listened to people talk over the last 2 days, and we've kept coming back to the idea of faculty development, and I've heard faculty need to learn to do community-based teaching, interprofessional, simulation. I think we've had very little conversation about the fact that our faculty are really aging, and we haven't had any conversation about faculty recruitment of the newer generation for whom a lot of these things would be much more familiar. I think it's important not to neglect that very important generational shift and recruitment responsibility.
Good. And Megan, if you could begin to shift over to the next set of slides, I'd appreciate that, and we'll keep on going.
Björk Palsutter from the Training for Health Equity Network. I just wanted to emphasize that as we think through developing community-based and community-engaged program, that we need to have the community as a partner in the whole process. If they are part of co-owning that, like Chichi was saying, the way they work, it's a different kind of experience. It's a mutual benefit. And I think that's really important because they will help guide through all the kinds of discussions we had, whether longitudinal or whether it's virtual or real. I think if they're partners through the process and in deciding what kind of programs, in working with and educating students, and as well as evaluating what success looks like. So I just want to encourage that they should be an active partner in the educational process. And I think all of it is really about slowly dismantling the ivory towers. So it should be, like somebody mentioned, I think, of the community. I think so I think that's something that's important to keep in mind.
Block by block, going that direction.
One thing that jumps out at me, a lot of the discussion, false dichotomies notwithstanding, thank you for being able to argue the false dichotomies and we basically came to the conclusion of 6 of one, half a dozen of the other on every question, right? So that's okay. But one thing that really hits me in going around this is that the things that we think pedagogically advance our education are perceived differently in medicine, differently in nursing, differently in pharmacy, differently in public health. There's some commonalities, but there's a number of areas, some went longitudinal and now they're going to blocks. Some went blocks and now we're going and I think the point is that you're seeing a really richness of good pedagogic techniques begin to emerge, whether it's simulation, whether it's virtual, whether we're talking about blocks or other kinds of experiences longitudinal. And so part of this breaking down silos, that's another theme that keeps going around, is how do you share all of that richness across these health professions, especially in light of the fact that we may be on an evolutionary trajectory in which none of our health professions 15 years from now will look like they do today. Mm-hmm. And if we're still alive in 15 years, we may look back and say, oh my gosh, the change was just unbelievable. Mm-hmm. And we had some role in pushing that trajectory.
Nice comment. Then we'll going that way. Yes, ma'am. And then in the corner back there.
One thing that struck me among all these topics is the limited discussion about the perspective from the student themselves. And I'm sure it was there, but I am thinking of the mentoring and the peer mentoring from one class to the next, whether it's I went through public health school and medical school, and what was similar across the learning process at the time, and this was in the 1970s and 80s, was really the students getting together and helping each other learn material, old exams, the student support and the student support groups. And I also come from California with a large Hispanic population of students in the 70s and 80s at UCLA. And African American students and Hispanic students getting together with the Asian students at the public health school because there were less minorities in public health than in medicine. And I just remember there was just so much more wealth of relationship building and also training on service learning, student clubs, and I'll just say leadership in general because of the organized efforts of the AMA and the AAMC and the family practice. All the different student groups that exist in this country are just a really wealth of training that we don't see in interprofessional consideration very much, because the public health students will go to the APHA or the medical students will go to their regional meetings, the county medical groups. But I think there's a need to rethink the concept of student clubs.
Good. Final comment in the back.
I think this mic is working. It's interesting to me, I want to go back to the comment about faculty, that I've heard very little conversations around faculty rewards, tenure, promotion, annual evaluations. Community-based work takes time. It takes away from scholarship and research often because building a real partnership requires investment that's not typically rewarded in a university system. This conversation will never move us forward. IPE takes time. It's very difficult to share a course between departments, even within a department. Those real issues have to be addressed as well if we want to change the culture.
Final comment.
I want to build on Elena Rios's comment because there are two physician groups. I, as an RN with a PhD, tried to join as an associate member and was flatly turned down because I was a nurse. And I'm not going to embarrass people in the room and name the organizations, but I think, and to my point, I don't know if there's any nursing organizations. I would think there are that would let physicians in as associate members. I'd like to challenge this group to start opening the current doors for more interprofessional practice to kind of, pave a way for when we, educate students in an interprofessional manner that we can continue the work after graduation.
Great. Thank you all for great comments, and thank you especially our sacrificial victims here.